Hello, my name is Moriah Fung. I am a member of the class of 2024, and I'm currently earning my degree in food and nutrition. And today I will just be sharing a bit about my research on health outcomes, food security, and resilience strategies among the Latinx community of North Carolina in the High Country. So for a bit of introductory material, we'll cover a little bit about what food insecurity is. As defined by the USDA, it is the inability to maintain consistent and balanced eating patterns, in addition to uncertainty about the source of a next meal. As of 2022, 12.8% of our population in the US was experiencing food insecurity. And furthermore, 20% of the Latinx population in our country was experiencing food insecurity. So this really highlights this population as one that we want to focus on to reduce those rates of hunger. We looked at the relationship between the social determinants of health and food environment and health outcomes. So we looked at food deserts, food insecurity, and lessened access to high quality nutritious foods, as well as language proficiency and barriers to support. And we just combined all these factors to look at how these were impacting negative health outcomes and how there was an increased incidence of chronic disease states in our population of interest. We really honed in on the Hispanic and Latinx community of Western North Carolina, including the counties of Mitchell, Ashe, Avery, Wilkes, Yancey, and Watauga. And we really wanted to look at these communities to identify their most prevalent negative health outcomes, their food insecurity statuses, and also understand the implications of what we can do in the future to ease the burden on both the individual and the health system. For our statement of problem, we again looked at current rates of food insecurity and their health outcomes, and then we also looked at the food assistance that they're currently utilizing. We looked at what was being successful, and we really worked to identify what are some future applications so we can continue to help reduce food insecurity and hunger. So for a little bit on methods, we first of all used a cross-sectional design to observe disease states, rates of food insecurity, and food assistance use. And our sample size was about 179. All of our participants were greater than 18 years old, and our recruitment strategy was convenient sampling across 12 months. So starting in the very end of 2022 and through the end of 2023, we were just gathering data. And this was on both a digital and a paper format. Lastly, our survey design consisted of 6 modules for a total of 57 multi-part questions. And these answered each of our objectives, which included what did food access look like, what was their food insecurity status based on a previously validated tool by the USDA, what were their rates of health outcomes, and what were their coping strategies, which included food assistance programs. We gathered some descriptive statistics using distribution, so mean and standard deviation for continuous variables such as age, and then frequency in percent for categorical variables. We also ran Pearson's chi-squared tests of independence and Fisher's exact tests to look at that association of English and Spanish with each of these factors. We then completed our analysis with a logistic regression, one of which was adjusted for language, and this was used to identify independent factors for the occurrence of at least one disease symptom, basically looking at what was predictive of at least one health condition. For our results, so for descriptive statistics, about half of our sample selected Spanish as a primary language. Average age was about 32 to 40. We had a majority female and then slightly less male, and then 2.1% was non-binary, and then 39% of our sample was making less than $25,000 a year. Our most prevalent diseases were obesity, anxiety, sleep disorder, and migraine. For each of these conditions, more English speakers than Spanish speakers were experiencing these disease states. We also looked at what are the disease states that are of interest in the US, or just in general public health, namely diabetes, heart disease, cancer, and hypertension. Surprisingly enough, these are pretty low in our sample, and we did look into that a bit further in our discussion, just to look at, was this underreporting, or is there actually something that they're doing well that is helping reduce these disease states? So on average, our participants experienced about 4 diseases, 3.82, and a majority of them were experiencing the symptoms of at least one disease state. Additionally, as you might have noticed from our distribution tables earlier, more English speakers than Spanish speakers were experiencing these disease states. And English speakers were experiencing almost 6 of these conditions, whereas Spanish speakers were only experiencing about 2. So there is a bit of a discrepancy there. So while this was, so this was a significant finding that language capability could be a predictor of what health status looks like. For food insecurity status, over half of our population was experiencing food insecurity, 55% of which were English speakers and 45% of which were Spanish speakers. Although I will say that this was not a statistically significant finding. We also looked at federal nutrition assistance programs, known as SNAP, WIC, School Lunch Program, and School Breakfast Program. And these were fairly low, so we didn't see much participation in these programs for both English and Spanish speakers. In terms of community assistance and food pantries, so you can see some of these listed here that were specific to the locale that we were in. We found that it was pretty common to use a food pantry. 52.9% of our sample indicated frequent or occasional visits to food pantries. And overall, our sample used about 2, more or less, food assistance programs that were not federally funded ones. Lastly, for our logistic regression, we found that food insecurity status increased someone's odds of having a negative health outcome by 229%, whereas using a federal food assistance program reduced those odds by 42%. And then using a community food assistance program actually increased someone's odds by 105%. When adjusted for language, these numbers stayed fairly similar, except the food insecurity variable became significant by the 95% confidence interval. And then community food assistance, that number changed to 66% increase in odds of having a negative health outcome. So for a brief discussion and conclusion, a huge amount of our participants were food insecure compared to, as we previously looked at, the nationwide rate of food insecurity in Latinx households. Some of those risk factors could include the fact that food deserts are common in the counties that we were in. Socioeconomic status was a big factor, meaning income was pretty low, which directly impacts ability to purchase food. Education level, social support, and acculturation were also some factors that we looked at more in depth that unfortunately we don't have time to cover today. Our most prevalent health outcomes were anxiety, sleep disorders, migraines, eating disorders, and fatigue. And this is the first study that is found in literature that has even looked at these disease states in this population. So there is a great deal of potential right there to continue digging into that to see how we can support them in treatment. Interestingly enough, diabetes and obesity were lower than the national average. And then we also found that all listed health outcomes were experienced in greater proportion by those who took the survey in English. Federal food assistance participation was below the national average for each of these 4 programs, SNAP, WIC, SPP, and SLP. But more than half of our sample was using the food pantries. So compared to the national average for Latinx households, using food pantries, which is 41%. This indicates that our population in Western North Carolina was really heavily relying on local community resources, which is great, but also not always sustainable. So we want to see how we can expand upon that. So with low federal assistance participation, but high community assistance participation, but we also saw that federal assistance has is associated with fewer health outcomes, whereas community assistance participation has a less of a significant impact. We can then conclude that we want our participants to use federal assistance more and rely on community assistance less. So essentially do the opposite of what they're currently doing. How can we overcome those barriers? How can we increase that participation? Well, recall that a higher proportion of English speakers were using federal nutrition assistance programs. So if that is the case, then really promoting English literacy or changing our resources to be more culturally relevant and to reduce those language barriers can significantly impact federal assistance participation. We saw that 42% reduction in odds of experiencing a negative health outcome when we combine those two factors, being English proficient and using a federal assistance program. So if we can encourage more people in this community to take those two steps, there is a great hope that we can reduce that burden on our health system. So for our next steps, with having reached these conclusions, we can really look to, again, reduce those language barriers, increase culturally relevant nutrition and health education, and then just strengthen the existing community resources to be more sustainable and well-funded. That way we can, join forces across federal, state, and local resources, and that way we can really just encourage this population to just have a better future, to find better health and know how to help themselves and help each other. Lastly, here are some of our sources. And once again, thank you for being here.